Welcome to The Point, a podcast by Apex Benefits and dedicated to employee benefits thought leadership. You can find more episodes for free on iTunes by searching The Point or Apex Benefits. Please rate, review, and subscribe to be the first to know about what we have in store for you. To learn more about Apex Benefits, please visit our website at www.apexbg.com or find us on LinkedIn, Facebook, or Twitter. Let's get to the point together.
Well, we're here today with Dr. Ryan Atkinson. He is a fellow Butler University pharmacist. He's also Senior Director of Specialty Pharmacy Strategy at Maxor National Pharmacy Services. So Ryan, welcome to the show.
Thank you so much. It's a pleasure to be here.
We are so excited to have you. You are one of our last conversations in the entire month of October around American Pharmacist Month, celebrating pharmacists here in the U.S. on past, present, and future related topics. You are, of course, part of the future because your area of expertise lies within specialty pharmacy, which if anyone is anywhere near pharmacy benefits, they know that this is the hot topic right now in terms of pharmacy benefit management. But before we get into all that, let's back up. I always ask the same question of all of my guests. How did you get to where you are today in your own career?
Oh, very good question. And I will say it's been a very long career as far as being in the pharmacy industry, and it's been very rewarding, and it's very exciting again to be here today and share this with you. So believe it or not, like you said, I went to Butler University. I'm not going to give the date that I graduated. It was quite some time ago, but I graduated with my PharmD and my MBA. Then I went on to do my fellowship with Eli Lilly in the visiting scientist program, basically learning about the drug development process, from pre-assay all the way to post-global marketing. So learned quite a bit about that process, made some excellent contacts within manufacturing, just learned a lot about the manufacturing process. Then I went to go work for WHI, which was Walgreens Health Initiatives, which was the PBM that Walgreens owned at that time. And I was in charge of several different projects. One of the biggest ones that I had there was MTM, or medication therapy management. Back in those days, it was just created as something that was needed for patients through the Medicare Modernization Act. So we created that program from scratch and really brought that on in a new way of thinking and a new way of revenue for pharmacists within the industry, but also, a new way to interact with and really treat patients, at that time older patients, but it went on to service many other demographics and age groups as the years went on. From WHI, I then went over to the Walgreens Co. side of things and had various careers within the organization itself. Walgreens is a huge organization, wonderful organization that really afforded me a lot of opportunity to work in operations, managed care, specialty pharmacy, a lot of which I did a lot of clinical management or clinical education in creating all of the clinical programs that Walgreens had at that time, and then working with our managed care providers to implement, create those programs, and then do outcomes research and publish those programs as well. And a lot of those, especially my last 8 to 10 years, were all in the specialty pharmacy space, which led me to where I am now. One of the gentlemen that I worked with over at Walgreens went over and became the Chief Pharmacy Officer at Maxor National Pharmacy Services. His name is Mike Einashofer, and he brought me over to the position I am now about a year and a half ago to lead the entire organization in regards to specialty pharmacy strategy, where we're going, what we're doing, what we're creating, what we need, and then also from the standpoint of limited distribution drug access, working with trade relations or manufacturers to expand our limited distribution drug portfolio. So it's been a very wild ride. It's amazing what pharmacy and my pharmacy degree has afforded me throughout my career. It's been wonderful.
Yeah, we were talking yesterday too about the present pharmacist role with a couple of gals that are in pharmacy, and we all remarked about how vastly different all three of our careers had been, in that, we didn't really take quote unquote traditional roles, and I really see you in that as well. You've had pretty non-traditional roles within pharmacy. So can you, for our audience, because they're primarily working in the benefit space for employers, give us a thumbnail view of what Maxor does as a company.
Sure, no, absolutely. So Maxor, we are what we call the oldest startup business in pharmacy right now. So we have been around for quite some time, but we have grown exponentially, almost 30% over just the past couple of years. So first and foremost, we are a PBM, or pharmacy benefit management company, but we also own and operate a managed care organization that used to be called as Gateway Health Partners. We also have our own specialty pharmacy. We have 4 different locations throughout the United States, full service specialty pharmacy, servicing all of our members as well as other members that don't actually have Maxor as their PBM. We also specialize in a couple of rare and orphan disease states, with our biggest one being cystic fibrosis. We have almost 15% of the CF patient population in the United States. Then we also have a 340B component of our organization, where we work with different hospital system pharmacies to set up their 340B space, but also run their on-site pharmacy. So they own their pharmacies, but we provide all of the inventory as well as all of the employees for those particular pharmacies. And then our most recent acquisition or partnership was with Cancer Treatment Centers of America, specifically partnering with them directly to run and operate all of their pharmacies that they have on their campuses throughout the United States.
Excellent. Thank you for that overview. And so let's take a deep dive into your world of specialty pharmacy. What trends are you seeing in your current role, Ryan, particularly around specialty drugs?
Sure, no, that's a great question. And maybe we should just start by defining what a specialty drug is. And the only reason I say that is it can really vary from institution to institution or organization to organization. But basically, here at Maxor, there's really 4 different criteria that make a specialty drug a specialty drug. And first, we start with the disease state. And typically, we see that these are chronic, complex, and or rare orphan disease states in the outpatient setting that goes through a specialty pharmacy. Normally, these disease states are referred to as either high touch, or they require enhanced clinical management or routine monitoring, to make sure that patients have positive therapeutic outcomes. And a couple of examples of this disease state, and remember, this isn't exhaustive by any means, but chronic inflammatory disease. An example that would be rheumatoid arthritis. Believe it or not, when we first started specialty pharmacy back in the day, the category just used to be rheumatoid arthritis, but because all of the drugs within that category have expanded indications, going from 1 to somewhere up to 12 different indications now for some of the drugs in that category, it has expanded. Multiple sclerosis is also another great example for this, as well as oncology. You see those as some of the 3 biggest disease states now within specialty pharmacy. Normally, these drugs also have to have special handling, so they have to have specific temperature controls along the supply chain. That what makes them specialty. Sometimes the way that they are administered also can be the way that we do it. If it's injectable, if it is IV, would also be an example. Although we have lots of specialty pharmacy drugs now that are taken orally. Oral oncology has exploded in the past 5 years alone, and so has cystic fibrosis, believe it or not, with the new drugs that have just come out for cystic fibrosis patients. Those are also oral therapies as well. And normally, cost is a third defining factor. Normally, these medications are considered to be higher in cost compared to non-specialty medications. Your typical or your traditional drug costs about $70 per fill, whereas right now the industry average for a specialty pharmacy drug is about $4,400. So pretty big disparity from that standpoint. And then the fourth, and it's not always a criteria, but it's becoming more and more a criteria lately, would be pharmacy access. And when I say pharmacy access, I mean limited distribution products, or what you'll hear as LDD. A lot of the manufacturers now, as they release their products, are using an LDD network of specialty pharmacies to distribute their specialty pharmacy drugs, and thereby classifying them as such. That set the stage, right? So this is me not answering your question, but setting up the question, right? So what are some of the trends? And I think you asked me specifically what we have been seeing within specialty pharmacy. So believe it or not, 50% of total pharmacy spend right now Now I'm quoting Maxor National Pharmacy Services numbers. So 50% of our pharmacy spend comes from specialty pharmacy drugs. So let me say that again, 50% of the spend comes from specialty pharmacy drugs. Now, of that, only 5% of my population use specialty pharmacy drugs. You have 5% of your patients using 50% of the pharmacy spend that is out there. So that's substantial. So normally we're seeing about 1% of the patients driving 71% of the plan cost. So that's a very, very skewed number if you think about it from that standpoint. And with the drugs that we see within the pipeline and what's coming out, also with the AWP increases within specialty pharmacy, we anticipate that 60% of all pharmacy costs just by 2022 are going to be specialty pharmacy. So significant growth within that area where you're seeing an expansion within oral oncology. You're seeing an expansion within some rare and orphan disease states, but not as much within other areas where we're seeing some substantial growth. We're also seeing some existing products getting expansions or additional indications, which is just increasing the utilization as well. So definitely seeing a large entry of new products, expansion of existing products, and more patients using specialty pharmacy medications.
Yeah, we actually did a blog post recently at Apex about specialty medications and what has been FDA approved in the first half of 2020. And we're seeing a ton of oncology, and some oncology is actually defined as orphan drugs as well, or orphan disease states, just by the simple nature of getting to the human genome and doing mapping to find rarer forms of cancer with particular patients. And orphan drugs is an area that I'd love to pick your brain on as well, because orphan disease states are rare, right? They treat less than 200,000 patients as a definition benchmark for orphan drugs. What are you seeing in particular around orphan drugs?
Oh, sure. Well, if you look at the drugs within the pipeline as of last month, 22% of the drugs that are coming out, or at least in the pipeline in the near future, are considered orphan drugs. So they're there. We're hoping that they come out. You know, the biggest one that we were anticipating was within hemophilia A about a month and a half, 2 months ago from BioMarin. And it was basically, for lack of a better term, potentially going to be a cure. I'm using quotes, you can't see me using quotes, for hemophilia A, and with a price tag of about $2.5 million. Now, they did not receive their approval letter, and it's not looking too good, and that's why I hate to, specifically call out a particular drug versus a disease state. But that just goes to show you, one, how one particular disease state, one particular drug can have a huge change, because we were just kind of treating hemophilia to potentially curing hemophilia with that drug that could have come out. But with a price tag of $2.5 million, then it came into big questions as far as who pays for that, what happens if there is failure of that product, do we need to have some type of contract in place with pharma that if they say this drug works but it doesn't, does the manufacturer then reimburse the managed care organization or the end payer in that standpoint? So there was lots of questions that came up surrounding that. But it's interesting with orphan, because as you said, very targeted patient population, but there's huge advantages for pharma to actually use the orphan, or go after an orphan drug status, because they get fast track approvals, they get longer market exclusivity. Sometimes there's limited to no competing products within that space. Sometimes, or most of the times, it's a novel mechanism of action for that product. And then we're also seeing a very big premium drug price that they can charge associated with that particular product. Does that make sense?
Absolutely. And you really brought up kind of an elephant on the table too that I wanted to talk about today, gene therapies. And I believe the therapy you were talking about for hemophilia A was one of those. Gene therapies are, from my understanding, there's hundreds of them in the pipeline. And what's really exciting about them is, I'm using your air quotes again, they are quote unquote curative, meaning that they could potentially cure a disease state. So can you talk a little bit about the gene therapies and where you see those heading in the future as well?
Sure. No, absolutely. And again, this is just from the experience that I've had within my organization and the research that we have done and a couple other insights from that point of view. The hardest thing, and I guess let me take a step back in regards to gene therapy, because it all depends where you sit on the fence in regards to the end payer. And what do I mean by that? So me as the PBM, a lot of these gene therapies are not necessarily going to fall on the pharmacy benefit side. They're going to fall on the medical benefit side. Why do I bring that up? Because you might see a lot of PBMs that might not have a particular way to manage these therapies or even budget for these therapies because they might not hit their bottom line. But then you shift to the medical side, then you have all of our managed care organizations that need to be monitoring the pipeline for these particular products and be budgeting for them, because if a drug comes out that's curative, in my opinion, you don't want to not pay for that product, right? But you definitely need to budget for it and also make sure that the appropriate patient is taking that therapy. So it comes from that standpoint. And then if you're the employer, now you're the employer that all of a sudden, wins the reverse lottery here, and you find that you have a patient or an employee that has one of these rare or orphan condition that now has a gene therapy that you may potentially have to pay for. You're definitely trying to figure out, one, how is that going to happen? Two, can I afford it? Three, is this appropriate? And then four, who can I work with at the manufacturer to actually afford this product that is going to be coming out? And I think there were talks with the BioMarin product, just as an example, coming out that there was going to be one specialty pharmacy that was going to be providing that particular product. They were going to be working with whomever would qualify for that drug on a payment program over amount of time, but then there was a value-based contract associated with it saying that if this therapy did not work, the manufacturer would reimburse for that particular product. Or if the patient shifted insurance during that time, that reimbursement or that value-based contract would go with that patient, instead of this patient was with organization A, they were good for 2 years. They're now with organization B, but that drug has now failed them. They have to take it again. That coverage actually went with that patient, and the new the new managed care organization wasn't responsible for actually being on the hook for that cost. So it's just amazing. And that was one therapy and that was one drug. So like you said, hundreds of gene therapies in the pipeline. And I think these are the types of conversations that are going to occur each time one of these drugs comes to the marketplace, because there's just so many pieces and so many people involved for such few amount of people that are going to be treated, if that's makes sense how I'm explaining that.
Yeah, absolutely. And we're having those conversations now out of the gate with our clients at Apex. It's so critical because, to your point, one $2.5 million claim on a plan that, spends a couple $100,000 a year on drugs could be devastating.
Absolutely.
So you work, at least at Maxor, on the PBM side, potentially with self-funded employers all day in your, setting, working with specialty drugs in particular. What advice do you have for them about, managing these claims, high dollar specialty, orphan drugs, gene therapies?
So if you are the self-funded employer, you need to use all of the resources that you have that are available to you. And the first and foremost, I would say, would start with your PBM. Your PBM most likely is monitoring the drug pipeline and will make you aware of any such drugs that are on the horizon. Number two, know your patient population, know your employees. Even if you're a larger self-funded entity, there's a good chance that you know what your patient demographics look like as far as age, race, sex, what other a disease state that those patients have. Potentially, they do have some rare or orphan conditions, and be prepared that some of the drugs within the pipeline could hit one of those members first and foremost. And then two, if that is going to be the case, be as proactive as you can. A lot of the resources that are available out there allow us to look at the drug pipeline 6, 12, 18 months out, and you can be prepared for these drugs when they do come out. And then once you do make that analysis or find that, the next step really is not only budgeting for it, but two, then working your manufacturer that's going to be providing that product to determine the best way to arrange for payment of that particular product. Is it a payment plan? If what you're pricing at it is that what it really needs? But then the specialty pharmacy on top of that can also look, because a lot of rare and orphan disease states have a lot of charitable foundations and organizations that are out there that we can work with to find additional funds for these patients to help pay for these therapies. Cystic fibrosis is a great example. Your average CF patient costs about $300,000 to $400,000 per year, but there are several foundations that are out there that raise millions and millions and millions of dollars every year to assist the 30,000 patients in the United States that are living with that condition to help pay for those therapies. So there's so many different resources that are available out there for the self-funded providers and their employees.
And I think the take-home message there for particularly people that don't have the privilege of working in pharmacy every day is go talk to your PBM. They can get the ball rolling.
They can. You'd be surprised how many folks don't consider the PBM or their counterparts at the PBM a resource. They're definitely, or we are definitely there to assist in any way we can. And we constantly monitor the pipeline, and we're trying to come up with the most clinically effective and cost-effective ways to treat our patients.
Yeah. Well, I want to go full loop and loop back around. You talked at the beginning about your own career path, and specialty pharmacy as a pharmacy career path for pharmacists seems to be exploding. So how else do you see pharmacy practice changing around specialty drug management? And are there opportunities there for pharmacists?
Oh my gosh, specialty pharmacy is going to look so different, in the next 3 to 5 years. So yes, I definitely think the specialty pharmacy one, it's the place to be as far as growth is concerned if you are a pharmacist. So I mean, as of right now, there's plenty of jobs that are available within specialty pharmacy, from being on the line and dispensing the drug and having conversations with the patients, to the development of all the clinical programs that go on for these patient populations. So I definitely see an increase in technology over the next 3 to 5 years. So why do I say that? So more and more of these drugs are requiring higher touch and more conversations with patients. Believe it or not, we are reaching out to our patients much more frequently. And to be able to do that with, one, not annoying them, right? Because we don't want them to not pick up the phone when we call, but also doing it at a time that is convenient for them, we have found has really taken an investment in technology. And be it, if it is via a text message, if it's providing them a web portal, anything that makes it more convenient for a patient to interface with their pharmacist and their specialty pharmacy, we have shown makes them more compliant, number one, more aware of their disease state, and more willing to reach out to us when they need to. A lot of patients don't like to pick up the phone and call anymore, or they don't like it when you call them because you most likely call them at the most inopportune time. So using technology to have them reach out to you at the most convenient time, or prompt them to reach out to you when it is the most convenient time for them, it's been absolutely huge. And then also just the educational piece that needs to go with some of these new therapies. A lot of it will be done over technology, but a lot of it needs to be done by someone that understands the disease state, the patient, and putting the two together. And the best person for that is the pharmacist. So we are expanding, at least within our specialty pharmacy, not only the technology piece, but the pharmacists that are able to have those conversations. And all they do all day is educate patient on their disease state and their drugs that these patients are taking. So you would be surprised how many patients, especially when they first get that new drug, it's daunting, and they don't have time to go back into the the doctor's office to actually have those conversations. So they're having them with the specialty pharmacy. The specialty pharmacy now, especially since patients can't be walking into the stores as much as they could with everything that's going on with the pandemic, you're seeing an increase in the use of video conferencing, and different platforms that promote that. So again, a big increase in the technology piece. There's also going to be a very, very big increase in a focus on customer service. I think more and more patients now, as they have access to more and more specialty pharmacies or ways to get their drugs, they're voicing more of a concern on where they can go and get their medications from. So I definitely think you're going to see more specialty pharmacies investing in customer service opportunities or even surveys, and going from that standpoint. And then the other piece that I'll say where you're going to see a big change within specialty pharmacy is based off of data analytics. So there is just so much data that is out there that we are really investing in the personnel and the people that understand that data, and then finding actionable next steps for that data. And that not necessarily isn't always with the patient. Sometimes that's with operations. So learning some particular patient populations that are more or less compliant based off of any number of factors, and coming up with either different operations to engage those patients or different technology to invest in to help with those patients. And then also on the manufacturing side, manufacturers love data and they need data. So it is up to us at the specialty pharmacy to discover new ways or new data points to even examine or capture that provide beneficial next steps to both us as a specialty pharmacy, but also for pharma, in order to get feedback on how well their medication is using, not off just their primary endpoints, but some secondary endpoints, quality of life things as well. And then you're also going to see that, well, just right now, Erin, we have seen so many different specialty pharmacies just opening. There was a large increase in the number of specialty pharmacies that were in the United States here just within the past 6 months. You see a lot of them opening within hospital pharmacies, which I find is very interesting,
Yeah.
right? So I think just the number of jobs that are going to be available in different settings versus if it's a standalone specialty pharmacy, if it's an independent specialty pharmacy, if it's a big box specialty pharmacy, or if it's a hospital specialty pharmacy. And I think each one of those will offer its own opportunity in the demographics and the drugs that it will be able to provide to its patients.
Well, with that, Ryan Atkinson, Senior Director, Specialty Pharmacy Strategy at Maxor National Pharmacy Services. How can people connect with you and learn more about you and or Maxor?
Oh, great question. So welcome to look me up on LinkedIn. I'm very easy to find on there. They are welcome to reach out to me via email, rjatkinson@maxor.com. I do a lot of presentations through Prime Education. So if they go to the Prime Education website, there's a lot of the webinars that I have done on there, as well as upcoming webinars that I work with Prime Education on as well.
Perfect. Well, with that, Ryan Atkinson, thank you so much for being part of Pharmacists Past, Present, and Future here at Apex Benefits.
Thank you so much. You have a great day.
You too.
You can find more episodes for free on iTunes by searching The Point or Apex Benefits. Please rate, review, and subscribe to be the first to know about what we have in store for you. To learn more about Apex Benefits, please visit our website at www.apexbg.com. or find us on LinkedIn, Facebook, or Twitter. Let's get to the point together.